So let's just talk briefly about some of the areas of concern when they're working on different parts of the colon, which is the large bowel, and what they'd be looking for, because they're looking for different things at different places. So if they were doing a right colon, as they're dissecting off the lateral gutter here and they're trying to make their window through the mesentery here, behind this would be coming the duodenum. And as we've talked earlier, they don't want to mess with the duodenum. So they would be looking for the duodenum. And the more you know as a first assistant, if you're assisting, the better you are, the better assistant you are, because you're an extra pair of knowledgeable eyes and an extra pair of knowledgeable hands. So that's your concern in the right colon. Now, if you were doing a left colon, they're going to be dissecting down here and the iliacs are going to be running down. You're going to see in the video at the end that the aorta is also in the area that they would be dissecting, and depending on where they are. And you also have the other vessels. If they're putting in trocars in the lower abdomen, they might have the inferior epigastrics, and those they might want to avoid hitting those vessels by having you illuminate with your scope underneath. And if they're not too thick walled, then you can sometimes see the vessels, the inferior epigastrics. So if they're doing a left colon, back to that, they're going to have the iliacs running down, and they're going to be looking for the left ureter. The left ureter may look like it's pulsing. They're going to have to identify, because there are other structures that look similar to it. So they're going to pinch it to try and see if they see peristalsis, and you as a first assistant are going to want to help with this, looking for it too. But it may be pulsing because at one point it goes over top of the iliac. So it's a referred pulse to it because it's lying over. So you can't go by whether it's pulsing or not. What they're looking for is the peristalsis. And then they're going to give a little pinch to make sure that stimulates the peristalsis, so they're sure it's the ureter, so they can be sure that when they're stapling the bowel and doing the resection that they don't accidentally resect part of the ureter. And I have seen that happen. When they're dissecting up on mobilizing the splenic flexure, they're dissecting it off the lateral wall here, and those attachments, it's the fatty mesenteric attachments, and as they're dissecting it off, as they get up this farther up here, they could, in the start detaching the Gerota's fascia, which is the fascia that covers the kidney, the left kidney. And that looks very similar. So they just want to dissect the upper layer that's the actual bowel attachment, and not the Gerota's fascia one. And we'll see that in the video that I post at the end of this series too. So they are concerned about that. When they're working in a low anterior and they're working down this area, there's also, and lateral, there are also some of the genital nerves that they have to be concerned about, and they don't want to cauterize or cut those, because then they're going to be affecting the patient's sexual function post-op. So they have to be aware of where those are and avoid those also. In addition to these anatomical concerns that they have, there's also the large bowel, the cause for concern, the risk of infection. So they're going to be coming to the operating room on prophylactic antibiotics, and they're going to be given antibiotics post-op. They're going to be monitored for pain and for fever and blood count, white blood count, and all those things to make sure that they can avoid any infection. And then they're also going to be looking for the bloodless plane, because getting in that bloodless plane will keep things as clear as possible, will decrease the bleeding that obscures the planes that they're looking for. So they're always looking for that bloodless plane.